to our session this evening. It's our monthly CME by Kenya Psychiatry Association, and our topic today is management of focal epilepsy by Professor Ndetei. So who is Professor Ndetei? He is a professor of psychiatry at the University of Nairobi. He's also the founding director of African Mental Health Research and Training Foundation. He's the director of World Psychiatry Association Collaborating Center for Research and Training here in Kenya. He's currently involved in over 15 collaborative studies with multi-centers spread over the globe. Amongst these is a biomarker project for early psychosis using cutting-edge technology, and the only center in Africa. He has 381 scholarly publications and a further 3 already accepted, and a number in different stages of review and preparations. He has authored 6 books and 21 monographs. He is also finalizing his 7th book, African Textbook of Psychiatry and Mental Health, which involves integrated clinical and public health approaches, which brings together multidisciplinary contributors from Africa and beyond. He is the co-author of and editor of the Tasman Textbook of Psychiatry for USA readership. He's a member of various professional bodies, co-editor of several journals, and honorary official of various academic institutions and associations across the globe. By nature, Professor David Ndetei is a publicity-shy person, amongst other things. He prefers to be called by his students and colleagues by his first name, David, a tradition inherited from some of the most outstanding global leaders in psychiatry and mental health. He accepted to present this webinar on condition that there would be no personal benefits, directly, indirectly to him whatsoever. So welcome, Professor Ndetei, and we're hoping to learn from you today.
Thank you very much. You can hear me?
Yes, very clearly.
Yeah. Thank you very much. It's really a pleasure to meet all of you online. These are some of the things that COVID-19 has made it possible for us. I'm so glad I travel less because I attend more meetings using this this forum. I think Nema has clearly stated my disclosures. Basically that I'm participating in this activity because of what is like to do in terms of spreading knowledge to other people. I have no personal interest in this, and I would not even accept anything directly or indirectly in kind as a source of participating in this exercise. Now, let me go straight to the presentation. I have to admit that there are very many abbreviations. You can see them on the screen. And I'm not going to spend time reading through them. This puts a limitation in the way we are going to understand the rest of the presentation, because they continue to use these abbreviations. So just bear with me. And should you want to get more information, I think you can go through the KPS Secretariat, and then maybe they can assist you in getting more information and details about this presentation. So just bear with me. It's a limitation, and we can't spend all the time going through this abbreviation. And in any case, it will be a futile exercise because you cannot remember all of them and you keep on going back. That's a limitation. And I would like to now share with you the outline of this presentation. Is very clear. It's spelled there in bullets, and I think you'll easily identify with this as clinicians. You can hear me?
Yes, we can
Yes.
hear you, but I cannot see. I can only see a folder, but we can't see your
Yes.
actual presentation. So I don't know whether
Oh.
you need to open the real presentation, unless I'm the only one. But the screen I can see is just a folder that probably contains your presentation.
Oh, you cannot see the actual presentation. Let me see if this helps.
In the meantime, as Professor Ndetei is setting up, I'd like to remind you about the Kenya Medical Association conference that is going to be happening in June. There's a psychiatry section for physician wellness or doctor's wellness, and they're accepting abstracts now. So please feel free to make an abstract and submit it to the KMA. Any topic on physician or doctor's wellness.
Can you see it now? Hello? Hello?
Yes, maybe double click on the Kepra, the slide, the presentation, you've not opened it. Perhaps double click on the folder, on the file Kepra. Or maybe Esther can project it.
Yeah, I was wondering whether Esther can share it from our end.
Yes.
Yes, and then I'll just keep on say move the slides. Would that help?
Yes, that's
Yes.
okay. That's okay.
Yeah, okay, fine. Okay, Esther, try to share it from your end.
All right.
Okay.
Is it visible now, Doc?
From my end, it is visible. I don't know from the others. From the
Yes, yes, it is. We can proceed now.
You can see it now.
You can put it on the slide mode, yeah? So that is bigger. The screen is bigger.
Okay.
So that we are
the slideshow.
At the bottom,
yes, just
for the minors.
Sorry?
Lower bottom. Just come to the bottom.
Uh-huh.
On your right, come to the right, where you've got minus and plus. The right of yourself, not the computer.
On the right of myself, huh?
Yes. There, okay. Yeah. Now before it, before the minus, click on that thing.
Mm-hmm.
Before the minus, come back.
Oh, okay.
Yes, that one.
Okay.
Good. Now we're good to go.
All right.
So we are good to go. We are now good to go, eh?
Yes, yes.
So you can see the abbreviations?
Yes, Doc.
Yeah, yes. I was saying that you would have to bear with us in terms of the abbreviation because we have very many, and it's not possible to remember all of them. And even if you memorize them, even if you learn them now, you still have to keep on coming back to see what they mean. So for those who will have some questions, they can direct them through the KPA Secretariat. Next slide. Can we go to the next slide? Esther? Esther? Can we go to the next slide?
Yes.
Yes, next slide.
I think Esther, you'll have to exit the presentation mode so that the rest of us can see when you move.
Okay.
Exit the presentation mode, we will see.
Where is that?
Just where you clicked to put it on presentation mode, on that icon down there on the right. Yes, now we can see you've moved to the next slide.
Next slide, okay.
Yeah.
But I need to go through that outline with you before we go to the next slide.
Okay.
Can I now say something about the outline?
Yes, and Esther will be taking you to the next slide as you request her. So Esther, please.
Esther, I want us to go to the slide on outline.
Okay, I have it on.
So the rest can see it, right?
Yes, we can.
Okay, very, very good. So the outline is there for you. And I hope this outline makes sense to you. A question that is asked all the time, which are the order and which are the new anti-epileptic drugs. This is a common question, which anti-epileptic drug constitutes first and second and third generation. We'll take time to look at this. And a good question is always, is there a significant difference in the efficacy between the older and the newer AEDs? A very question that we ask all the time. Is there a significant difference between the long-term retention rates? Is there a substantial difference in tolerability, long-term safety of new versus old AEDs? Key comparisons of older and new AEDs, and then out of that, we will come to what you may consider to be logical conclusion. Next slide. So here is a summary of the various AEDs as I've just indicated. The old ones, older generation, which came before 1960, and then a second order generation that existed for only 15 years, 1960 to 1975. And if you look at 1857 and 1860, we're talking about nearly 100 years of transition. And within 15 years, as far as the older but new generation, you can see a lot happened within a very relative short time. Now, the one that were known before 1960, they are listed there. Of course, the one that is very well known is barbiturates and structurally similar drugs. And there are some that they are there. We have all heard of them, like phenytoin. We have all heard on phenytoin. It's still used by, it's still used today. Doxoxamide, been around for a long time. And then the newer ones are there, which are clearly labeled. I think we all know about carbamazepine, valproate, clonazepam, and clobazam. This we know. And now, more recently, we have a wide range of anti-epileptic drugs, really wide range. And the question is there a difference in terms of efficacy and in terms of the other consideration that we enumerated? I think I will not go into the details. They are all going through each one of them. They are very clearly stated. Maybe I'll give you just a moment to have a guess and then before I go for the next slide, so that you have a pretty good idea on the newer generation of AEDs. Good. I think we can move to the next slide. Esther. Now, choice of AEDs must be individualized. I think this is a very important consideration, and there are very many reasons for that. I think we are all very different in terms of genetic makeup, and I am aware of the technology that is being developed, or in very many countries. There are few centers in Europe and the USA where go. Yes, yeah, where actually people can go to a laboratory and be tested, and depending on their genetic makeup, they can be told this is a possible anti-epileptic drug that is going to be suitable for you, as opposed to another person, maybe with the same clinical features. Very much similar like what we do when you do culture and sensitivity, and we can tell and advise the patient that this is the best antibiotic for you. I think we are coming to that in terms of genetic studies. The choice of individualized treatment for epilepsy is based on very many considerations, and depending on the seizure and the epilepsy syndrome, where those dependent adverse effects, idiosyncratic reaction, we are all very different in terms of how we react to particular drugs. Sometimes there's no immediate explanation, or it may just be, you just know that this person has got this reaction once you start giving them the medicine. Chronic toxicities, teratogenicity, when you are talking about mothers who are pregnant, carcinogenicity, pharmacokinetics. And here, when we start talking about pharmacokinetics, we are getting very close to genetic factors. And the interaction potential, some of these drugs may interact with other patients, other medicine that could be taking, and the types of formulations. And of course, those are important things that in general are important related to the choice, but there are also other things with the individual, the age, the sex, possibility of pregnancy, co-medication, comorbidities, genetic background, which we have just talked about, and other things that are outside the control to a large extent of the patient, the insurance coverage, because it will also depend on whether the cost of the medicine, and therefore it will depend on whether basically whether the patient will be able to afford this, whether paid by the insurance or the relatives. And of course, sometimes the ability of the patient to swallow the medicines and so on. We know that when we are dealing with the psychiatric patients who have epilepsy, there could be issues of the loss of insight, and they may not even want to take the medication. Or people will tell you, I'm sure many of you will have seen this, as I have also seen, that these seizures is not a medical problem, is a supernatural issue, maybe demon possession and things like that. And we have seen patients who, for a long time, they refuse to take the medication because they don't quite agree with what you are saying. Next, and of course, it will also depend on the availability. We have seen a very good list of, a long list of these drugs, but are they available in the country? And if at all they are available, what are the costs? And this is also related to very individualized considerations, things to do with whether they or the relative can afford to acquire those medicines. Shall we go to the next one? Next slide. Esther, are you there? Yes. This is another way of looking at the factors that are important in the individualized choice of the AEDs. We have formulations, the chemical structure of these medicines, interaction potential with the many other things that would be happening, pharmacokinetics that has to do with the genetics and the metabolism, and the different enzymes that are associated with the metabolism. The seizure and of the epilepsy, the syndrome, and there are different types of seizures as you see in a moment. And those independent adverse effects, which we also alluded to, idiosyncratic reactions, chronic toxicities, and teratogenicity and carcinogenicity. Move on, next slide. Next slide.
I've moved, Prof.
You have moved?
Yes, we are on slide 7.
Yes. Yeah, it's again, it's a continuation of what we have been saying: ability to swallow pills and tablets, relative wealth, insurance coverage, genetic background, age, sex, possibility of rather than sex, or shall we say in gender, possibility of pregnancy, co-medication, and the comorbidities. And we as psychiatrists, we know very well that people with epilepsy can have other psychiatric conditions, and depression is common, anxiety is common. And in some cases, when this condition has been going on for a long time, particularly temporal lobe epilepsy, they can develop schizophrenia-like syndrome, a condition that I think was discussed very well and articulated, I think, in the early 1970s by Elliot Slater from Queen's College, Queen's Hospital in London. So we know that epilepsy can coexist with many other conditions, maybe head injury, identifiable brain disorders, and identifiable psychiatric conditions. So all of these things must be taken into account. Next slide. We need to move. Yes. And it's a continuation of what we have been saying. And I think the fact that we have these several slides on the individualization on the choice of AEDs that are available, or the ones that we have decided to prescribe on for individual patients, is again is very important. And therefore, I believe the reason why we are spending quite a bit of time on individualization. We have talked about availability. We have talked about what is available in the country. And if you talk about public facilities, government funded, definitely the economy of the country and what they can afford, priorities will definitely influence the choice of this medicine in specific hospitals and government facilities. And of course, all of these are related to the cost, whether at the level of the individual, whether in the private sector, but more importantly, I think most of our patients go to public facilities, the economy of the country. I think these are things that we all know and have experienced. So I am not telling you anything new. I am just reminding you that what we already know from different perspectives is like I'm just putting these things together to remind ourselves that these are the realities that we all go through. Next slide. Yes, and another consideration is the type of seizure that we are dealing with. Epilepsy type and epilepsy syndrome, all of these things are very important. If you talk about seizure types, we all know this is something that we all know. Is it can be focal, it can have a focal onset, and we can identify either using EEG or using advanced technology. We can see if there's a tumor, we can see where it is. So we can say there's a focal onset which we can identify. And this focal onset can generate to influence the whole brain. For example, we know very well the clinical presentation of temporal lobe epilepsy, with the very classic presentation. More often than not, they may not go into generalized fits, but a few of them can go into generalized fits. But there are also other seizures that occur, and we cannot put a finger at a particular part of the brain where it is originating from. So we talk about generalized onset, and of course, we must admit that there are times when you really don't know where the cause is. And related to seizure types is epilepsy types. As we talk about focal, generalized, sometimes a combination of both of them. I just talked about temporal lobe epilepsy not going into full seizure, and sometimes not going to full seizure. So you can get a combination of generalized and focal, and sometimes we must admit there are times when we really don't know what's happening. These are limitations. Maybe future technology would help us in doing this. Now, yes, those are what I was telling you about, those abbreviations. I think please don't bother too much about them at this point in time. Next slide. Next slide. Yes. Yeah, that arrow just indicates how focal or focal onset or generalized onset can lead to the different types of epilepsy as we know them. I think this is quite obvious to all of us. On the right side, which is the abbreviation, you can see the narrow spectrum types of drugs that will act on either local, when we are dealing with the local seizure type, they seem to be a narrow spectrum acting on a particular type of seizure, and others which seem to have a broad spectrum effect, whether you are dealing with focal, generalized, combined, or sometimes unknown. Those abbreviations there are about different preparations that are available in the market. Next slide. And of course, yes. So then, with that kind of knowledge, that kind of background, what is the strategy and outcomes with anti-epileptic drugs as we know them today? There are several ways, about 3 ways in which you can administer these anti-epileptic drugs. Initially, there's initial monotherapy, where you are using only one type of AED. And it's been shown that 47% of the seizures can be controlled using monotherapy. And I think that's good news, that we can control nearly 50% using one drug. That is very useful for the patients. It increases compliance. It also decreases the cost of using different medications, and also it decreases the possibilities of interaction across different drugs. And now, the initial medicine that we use may not work, and therefore we are forced to look for an alternative monotherapy. And I want you to notice that we are emphasizing monotherapy rather than polypharmacy. I think in one of the WhatsApp communication, we have seen polypharmacy. And somebody raised this issue of polypharmacy, and it was, I don't know who it was, but it was one of us. And I think that was a very important observation, that we tend to go into polypharmacy even before we systematically go through the first initial monotherapy and then alternative monotherapy. And the good news is that we're using this kind of approach. We can control seizures in nearly about 64%. That is about nearly 2/3 of all the cases that we have. And then eventually you can talk about polytherapy, and we probably need just about 3%. And 30%, and the remaining 30%, which we really, quite more often than not, we really don't know how we get to this when we have tried all of these things, and we probably consider other types of drugs. So if you look at the left side, we are talking about a monotherapy, and then down the line we are talking about polytherapy. And as I said, there are times when we don't even know what is going to work in this particular patient, and it does not work for all of them. And we start talking about drug-resistant epilepsy. And I think these are some of the clinical frustration that we all go through. And if they happen to you, please just know you are not the only one. It's something that has been observed in very many situations. I hope that is kind of counseling for us. I think just for us to feel that we are not the only ones who go through these difficult experiences. Next slide. So, given all this, we have to make national rational management of drug of choice. And that one, at the bottom, you can see this paper that was published not some time ago. It's been there for nearly 19 years, but I think the quotation is very important. As there are no major differences in efficacy among first-line and epileptic drugs, tolerability and safety must be the paramount consideration in patients with the often mild, newly diagnosed epilepsy. I don't need to elaborate this. What is being said here is this, that in terms of efficacy, there is a lot of similarity between the various AEDs that we know of. However, there will be problems in terms of tolerability and safety that need to be concerned. But shall I say the side effects? But efficacy is more or less is basically the same at the very early stages in the choice of drugs. But of course, as we all know, different side effects. And it's true, even when we are using some of the antipsychotics that we know of, starting with haloperidol and all the others that we know, going all the way to clozapine. I think I've seen papers that have said, and extremely very well argued with the very good data, that some of the older generation of the haloperidol and things like that, the efficacy is basically the same, but the difference will be in the choice. The choice will depend on the side effects that are available, that are attributed to the various drugs, how they tolerate them, and whether they are safe or not. So we are talking about these side effects. Next slide. Then it's also very important that we all practice evidence-based medicine in the treatment of epilepsy. The evidence that is already available here is summarized. And when I talk about here, I'm not just talking about us here in Kenya. We are talking about the evidence that is available and globally, because the practice of medicine is really becoming a global phenomenon where evidence coming, say, from, say, UK or wherever, or even some very good publication that occur locally, and I'm sure these are some of the things that here in this country we can start looking into. We know that we should be happy that what we are practicing now, you can't say this is how it works in Kenya and works out Kenya alone. You can say this is the evidence for doing what I am doing. So this will depend on the seizure type or epilepsy syndrome in adults with partial onset seizures, children with partial onset seizures, and the AEDs that are already associated with that are over there given in terms of the various AEDs that are available for adults, for children, and the elderly adults with partial onset seizures. Again, becoming a very common problem here. I don't know how you're experiencing this, and we are increasingly seeing elderly patients either with the dementias or with other brain-related disorders as a result of the old age. We are seeing increasingly more, and I think it's not just me, it's all of us, clinicians. All of these things are very important. Look at the elderly adults with the partial onset seizures, the kind of things that can be used, a kind of AEDs that can be used. And these are nice guidelines in terms of evidence. So we have evidence from different guidelines, and so I'm putting these, when we talk about these different guidelines, they are not just ours. They are global, and very many people use this. But also remember, because of the metabolism, people from different races, like people from, say, Africa, I think, or even America, everywhere, it has been shown that there are different factors in terms of how medicine are metabolized. And I can tell you, when I was training in UK, I saw people getting very high levels of different types of antipsychotics and epilepsies and epilepsy. And when I came here, that was not the case. And then the information started coming through that this might be a reflection of our different capacities to metabolize drugs. These are some of the things that you have to consider as you make that decision. Next slide. Next slide. Esther, where are you? Good. Yes. So the question is there a significant difference in the efficacy between older and new AEDs? This was one of the issues that were raised, one of the outlines. And is there a significant difference in the efficacy between older and newer AEDs? No. no significant difference. The efficacy of many but not all new AEDs for treatment of new onset epilepsy is similar to that of older AEDs. And I think I like this because it is a very honest statement. And I'm saying this because you guys, like me, we get very many people, drug companies, coming to the office to see you and trying to convince you that this preparation of mine is better than that other preparation. And I have also seen, I don't know what has been the experience, 2 drug representatives working for the same company, and each company, and those companies have 1 or 2 more preparation of these, of a particular type of category of drugs. And you begin to see competition even between these representatives, like competition among themselves. They will come and tell you this brand is different from this. Yes, we are the companies. And then the other person will come and tell you, no, forget about that. And then when you discover that is really is business oriented rather than evidence-based, then you begin to realize that there is a problem. No substantial improvement in efficacy of drug treatment for epilepsy. Data does not indicate an improvement of prognosis since introduction of new AEDs. Can you go back? I don't know what has happened to my screen. I don't want to. I don't know what has just really happened. Let me just call for help. Esther, what has happened to? Yes, I'm back. So, and I don't remember, about 10 years ago, the American organization that registered medicines, for some time, they had refused to register new psychotropic drugs in treatment of depression, and they said, we don't want to we are not prepared unless you can demonstrate convincingly that what you are telling us is an improvement on what we already know. And I think this was, if I remember very well, this was prompted by an observation in the United States, and there was an editorial on this, which went to like this. We in the United States, we have the money, the government can, we have insurances, so we can have access to any of the newest antipsychotic or antidepressant that is available. And because the people from low and middle income countries cannot afford, so these medicine get prescribed in those particular communities. And then after some time, they discover, yes, these medicine were efficacious in terms of reducing the symptoms, but they had problems that had not been anticipated because they require long-term observations. And therefore, this was their conclusion, which was very honest conclusion. Because we are rich, we can afford all these new medicine. They are developed here. We succumb to the marketing gimmicks of the drug companies who want to recoup their expenses. We, the Americans, people in the high-income countries, we have become guinea pigs. And by the time they get to low and middle-income countries, because the patents rules have run out, they are cheaper. But we know better the side effects. So this is a very honest statement. So guidelines recommended both older and newer ADC on the basis of equivalent efficacy. So basically, we are talking about recommendation guidelines between the old and new ones is basically on the equivalent efficacy. Can we move to the next slide? Esther, next slide. Now, this is a very important one because again, the reduction rates will depend on the pharmacokinetics, and we are talking about, when we start talking about pharmacokinetics, we are talking about genetics and metabolism, and as I said, these vary greatly. So retention is the percentage of patients who started taking a drug, who remain on the drug after a period of time. We all know this. Composite measures of efficacy, seizure control, and tolerability, which vary greatly, can also be referred as effectiveness in reflecting how a drug performs in the real world setting rather than a tightly controlled clinical trials. What are we saying? We are saying at the end of the day, it is what the patient, it is what that patient, the one you are dealing with, how they accept that particular treatment. And sometimes we may say, don't talk about tightly controlled clinical trials, because those clinical trials cannot take into account the genetic variability from one person to another, leave alone across different ethnicities and different genetics. When they say that when people start talking about genetics in terms of identifying particular people, it tells you that we are all very different genetically. And these are some of the things that may explain this. Side effects in terms of tolerability, they really vary greatly. I think this is a fact that we all know. So it depends on how long these patients will continue to take this medication for various reasons. Next slide. Now, is there a substantial difference in tolerability, long-term safety of new versus old AEDs? Very important question. Let's look at it. Next slide. These are the things I've been talking about: enzyme induction, and drug interactions, comorbidities in terms of the other conditions that are in this patient, side effects and adverse effects. Women with epilepsy, and we will talk about that later on. Move on. This is what I've been talking about. Hepatic enzyme induction. We all know this, phentoin and carbamazepine, particularly carbamazepine, is known to be an enzyme inducer in the liver. And as for when people take this medicine for some time, they may develop tolerability because the liver learns to respond to that medicine, to cognize very early as removed from the stomach through the liver, and the enzyme that breaks carbamazepine is enhanced in terms of quantities, and therefore the doses may become less effective with the time. This is a result of cytochrome P450, and this is one of the enzymes that has been widely studied, and people have found different levels of this enzyme in different different patients and different settings. As I said, it can induce inhibitors and so on. And there are different types of drugs that will be affected in different ways, depending on the cytochrome 450. However, there are some medicines, ADCs, that don't seem to depend on the levels of cytochrome 450, and they are listed on the right side: negligible, no effect in the metabolism. So when you are dealing with the phenytoin, carbamazepine, which are very widely available here, as valproate, and this other one, just remember that they could become less effective as time goes by, and therefore there's a bigger choice on the right side, which is listed there for you. So hepatic enzyme induction, a very important concept in understanding the behavior of some of these AEDs. Next slide. Enzyme induction, maybe we spend a little bit of time on this. Enzyme inducers stimulate the de novo synthesis of metabolic enzymes, accelerating the clearance of, that is exactly what I said, so that they increase clearance of main lipid soluble drugs, and they are all of them. It's not just in epilepsy, which occurs in very many other use of other medicines. Antinoplastic engines, some endogenous hormones, vitamin D, sex hormones, cortisol, and the list goes on and on and on. It's difficult sometimes to have experience with every one of these medicines, these available drugs. I think you start from what you know and move on from when you start with what you know and it doesn't work for you, you move to the next available one, because you cannot start with a patient, any patient, and say, for you, sir, or you, madam, is going to be like this. It is a question of trial and error. So by accelerating the metabolism of lipid-soluble drugs, enzyme induces help us to alternative helps to alternate their pharmacological effects. Next slide. There is a continuation. Enzyme induction increased vascular risks, osteomalacia, osteoporosis, sexual dysfunction. So enzyme induction, apart from reducing the effectiveness of a given drug, can also lead to other conditions. So we must be very careful when we are talking about that. It's not just the effectiveness, the altered effectiveness of a given dose. If that is happening, and quite often happens with the carbamazepine, and the only reason why we talk about carbamazepine, because it's been used for a long time, so we know a lot about that. So if it's, say it's not, there's an element of enzyme induction, also think of other possibilities which are there. And of course, you need to be, if that is happening, then you need to change as quickly as possible. Next slide. Increased vascular risks. This was a study that was conducted. And let me just say on the right side what was found. Patients with epilepsy who were receiving long-term monotherapy with carbamazepine or phenytoin. Remember I said carbamazepine and phenytoin are those that have been very well studied of a long time, manifests significant increases in total cholesterol. And we know increase in total cholesterol is not good for very many reasons. The changes in total cholesterol with the valproate monotherapy was not significant. we are talking about carbamazepine and phenytoin because for a long time we know this, they have been used. And the sodium palmitate, which is again used here, but has got its own problems, has not been shown to be that. And we know from other studies that sodium palmitate, even though it may cause enzyme induction, is not as much as carbamazepine and phenytoin. So this fits into clinical experience. Although I keep on saying clinical experience is good, but must be supported by evidence base. Next slide. Increased vascular risk, elevated cholesterol levels, patients taking enzyme-inducing AEDs, monotherapy manifests elevation of cholesterol and C-reactive protein. Long-term monotherapy with these enzyme inducer was associated with increased common carotid artery edema thickness, that is the thickness of the wall in patients with epilepsy. So elevated C-creatine proteins, increased common carotid artery thickness, things like that, we know are very important in terms of the cardiovascular function of that patient. And of course, we know that if that is compromised, it has got its own adverse effects. Next slide. Again, related to what we've been saying, increased level of total cholesterol, LDLs, and all those different types of treatment conditions, metabolic changes. So monitoring of serum cholesterol and high homocysteine levels in patients, and that is very, very well highlighted. Please remember that. A very important take-home message: carbamazepine, phenytoin, and the phenobarbital. I think phenytoin is tends to be used more by neurologists for whatever reason. But just remember that, especially when we are dealing with the elderly patients. I don't know what has happened again to my screen. Yes, I'm back to normal. Okay, can we move on to the next slide? Effects on the various parameters is there well detailed. Calcium, phosphate, alkaline phosphatase, and all of those that are bone reabsorption, bone formation, bone reabsorption, bone turnover, and you can see how they can reduce this. I think this is really very important for us to know that even when as we continue to prescribe some of these medicines, there are times when it may be necessary for you to just do these tests to see which way we are moving. Enzyme inhibitor, see these are enzyme inducers, they are there. Others which are not enzyme inducers in the middle, and no enzyme effect again on the right. Very important guides as to the choice of long-term use of AEDs. Next slide. Now, so consideration initial AED selection. We are talking enzyme induction. We talk about drug interactions now, and then after that we talk about comorbidities, side effects, and adverse effects. And women with epilepsy, we'll be doing that. So we need to move a little bit faster so that at least we'll let you go home and be with your families. Can you move to the next slide? Let's start next slide. Drug interaction. Of particular importance in the elderly patients, mean number of prescription medication in the elderly population is 6.7. for various reasons, by the way, not just because of the epilepsy, but because of, remember I said these people may have other conditions. They may have metabolic diseases, diabetes, hypertension, which is very common at that age, with dementias and all kinds of things. So you get a patient, not only a patient who is being treated for epilepsy, but also being treated for other conditions. And when you start talking about 6 to 7, nearly 7 types of drugs occurring at the same time, targeting different conditions in that patient, then you can expect that you are going to have what is going to have polypharmacy, not polypharmacy on the AEDs, but polypharmacy because other conditions are being treated. So AEDs are among the leading medication responsible for drug interaction for the various reasons that I've stated. Most drug interaction can occur with the cytochrome 450 enzyme system, which I've already talked about, and the co-administered medications. Move on. And of course, there are those ones that I've started. So anyway, let's move to the next one. Rate of drug interaction potential of AEDs. None. Now we are talking about AEDs themselves. None, minimal. Those are the ones that are likely to cause no problem on the left side. None or minimal, or low, again, on the right side. And I think from there you can easily pick things like lamotrigine. And these are things that are of interest to us as psychiatrists because some of these medicines are also used as mood stabilizers. And high, we have already talked about that, carbamazepine, phenbamate, phenytoin, and phenobarbital, and so on. I was surprised that in some cases, people still use phenobarbital today for various reasons, of course, based on their clinical judgment. I'm not criticizing anybody. All I'm saying is that these medicines are still widely used. Move on. Now, that's a little bit complicated. We are not going to go into the details of all of this. We are looking at the AED drug interaction, expected changes in serum concentration levels when AED is added to an existing AED. I don't think really I can break down that slide. I can only assume that you can go through KPA to be able to access these things and study them with a toothpick for you to grasp that chart. And with that, I just want to say that this has been demonstrated to exist, and you need time to understand all of this. Now, shall we move on to the next slide? Now, consideration, we talked about enzyme induction, we have talked about drug interaction. Let's talk about comorbidities. And I think we need to move a little bit faster. So, next slide. Well, comorbidities, well, they are out there, aren't they? We have neuropathic pain. People use carbamazepine, gabapentin. Migraine patients, we use palforate, tomipramate. Mood disorders, we have just mentioned about that. Carbamazepine, oscarbamazepine, palforate, lamotrigine. Anxiety, those are used. Essential tremor, all of those. So these different comorbidities, that is different. The different physical conditions that require different. That can require use of AEDs. So just remember that these drugs can be used in other conditions, not necessarily AED, not necessarily epilepsy. We all know that anxiety is very common, migraine headaches, and so on. Of course, not to mention mood disorders, not to mention neuropathic. These are conditions that we all deal with this. And I think here is where there is a big interface between psychiatrists and the physician, and in particular neurophysicians. And I think we need to work together instead of working in silos, because there's a lot of information that we can share. So next slide. And again, as I was saying, there are people with the comorbidities, that is people with epilepsy. They can have heart disease, cardiac arrhythmias, lung disease, hepatic impairment, renal impairment, porphyria. And the porphyria, when you have it, can be extremely painful. I've seen not very many patients. Liver transplantation, where it is kidney transplantation, bone marrow transplantation, hypothyroidism, osteoporosis. Favorable AEDs to use in when you have those, any of those, is there summarized for you. As I said, these are abbreviations. You just have to go back with a toothpick. AEDs to be avoided when you have those conditions, like if you have a heart disease or cardiac arrhythmias, please avoid those. If you have lung disease, try to avoid those which are listed there. Porphyria, a long list. As I said, I don't know what your experiences are, but I have seen not very many cases of porphyria. If you are seeing patients with porphyria, if you are seeing a patient with porphyria and all those, please remember this slide. Remember this lecture. You can't remember all of these things. You say, oh, I have got a patient who got a heart disease, and he's also has epilepsy. Let me go and check from that lecture or from literature what I should be careful about when I'm dealing with epilepsy in a patient with that condition. I think that's the best that I can say, because you can't, I don't think anybody can do all of this, put it on their minds so that they know, like as if it was a computer in their head. Next slide. And you see it continues. Obesity, HIV, mental disability, cognitive impairment, stroke, brain tumor, cancer, hyponatremia, skin rashes, depression, and it goes on, even SARS and various variants of COVID. Very important these days because of these many conditions that we have to deal with. Next slide. Now, let's go and talk about side effects and adverse effects before we talk about women with epilepsy. Can we move on? Effects of AEDs on body weight. There it is. There are some which are neutral, others which will lead to increased weight, others which will lead to increased weight. Phenytoin seems to be neutral, lamotrigine seems to be neutral, tiagabamine needs to be neutral. I don't know whether those ones are available here. Weight gain, palforate, carbamazepine, gabapentin, I'm talking about that are available here. Weight loss, and again, the choice is there if you want to see it. Shall we move to the next one? Next slide. I think we are getting close to the end. AED effects on cognition, mood, and behavior, very important for us, by the way. As psychiatrists, gabapentin, lamotrigine, I'm picking this randomly. Behavioral disorder, I think, is a little bit tracetam, topiramate, and a few others, just for you to bear in mind. Yes, so then if you are using these, you see this behavioral disorder, you want to be sure that is not as a result of the AED that you are using. Next slide. Summary of comparisons between old and new AEDs. Let's see a summary. Next slide. Advantages, relatively cheaper price, familiarity with the use, that is all AEDs, familiar with use, guidelines recommended, and disadvantages, pharmacokinetic characteristics, high risk of idiosyncratic reaction, limited use in special population, especially elderly, pregnant patient with multiple comorbidities, need for monitoring drug levels, mostly narrow spectrum, limited choices, potential for drug interaction. So that is one of, those are the advantages and disadvantages of the older generation. I don't want to, I'll leave it to you, to your clinical decision. The fact that the disadvantages, the list of disadvantages seem to be longer than the list of advantages. Again, that is a clinical decision. Of course, discuss with the patients and other things. New AEDs, they have advantages, comparative efficacy with the new old AEDs, improved tolerability. Remember here, we are talking about side effects, better safety profile, better pharmacokinetic properties, less serious adverse reaction, low or no drug interaction, ease of use, no need to regulate drug levels, and the price can be a very big issue. And I think that's just a summary of the things that you have been talking about. As you can see, out of all those disadvantages, there's nothing to do with efficacy, which was something that we emphasized right from the beginning. But price is a big issue. And we keep on, I think we all have a different experience and times of prices. One time I was given some medication by a drug company, and for this guy, for a certain type of treatment, and I got a patient, I thought they needed that, they could do very well with that medicine. And I said, because one of the regulations, one of the requirements that you must take it 3 times a day on a full stomach. So I said, I have this medicine, it's not going to cost you anything because it was given to me for free. I'm going to give it, but on the condition that you must take it on a full stomach. And the patient was on his service, said, please, I'm not going to take it. I give it to somebody else. I hardly have 1 meal in a day. So I cannot take it because I can't have 3 meals in a day. And again, many patients, if they are honest with you, they tell you, yes, we are going to buy, we can afford this medicine, or they tell you, okay, fine, since you have said so, we try our best to do this, and in the process of getting that medicine, other things go wrong in the family, there's not enough food. Basically, what are we saying is that for every patient, please discuss with them what they think about the medicine in terms of cost, all the things that we have been talking about, so that as you make the decision, is not just your decision, is that the patients, you take them along, so that, because that is going to enhance compliance. Next slide. Next. Advantage, disadvantage, or key AEDs, phenobarbital, advantage, low cost. I think phenobarbital is used, but it's almost for free. I think it costs very little. Disadvantages are pharmacokinetics and things like that, cognitive and behavioral action. And I remember one time we were talking about behavioral epilepsy in school-going children in a certain forum, and it was being given by physicians and the neurology left and right. So we wondered, why were they doing these things? He said, because it is affordable. Yes, it's affordable. They can, and very effective, by the way, in controlling fees. But what did they do to the education of those children? Because of cognitive and behavioral, cognitive function in that patient. So you have to balance all of this. And then you can go down the list, phenytoin, carbamazepine, Powerage, and all of those things, advantages and the disadvantages. Next slide. And it continues for the different AEDs that are available to us or on the market, whether Kenyan market or global market. Move on. So, my dear colleagues, ladies and gentlemen, what are the take-home messages from this interaction? Number one, choice of an epileptic drug for your patient needs to be individualized. And when we talk about individualization, is individualized on the basis of everything that we talked about. Gender, affordability, whether they are going to get the medicine, the economic status, pharmacogenetics, comorbidities, it must be individualized in very many ways. And you remember when we were having a discussion on this, on the individualization, I think it was the longest section in this presentation. Key consideration for AD choice includes seizure type, AED, spectrum of activity, age, comorbidities, co-medication, especially when you are dealing with the elderly, adverse effects, profile, and tolerability. Newer generation of AEDs have the advantage of comparable efficacy. Remember, comparable efficacy with better safety and tolerability. So it's better safety and tolerability rather than efficacy. I think that has come out very, very clearly. And remember when I was complaining, well, not complaining, but saying, yeah, phenobarbital, you are giving school children with these things, we said, yes, because it's affordable. Yeah, but what about the education of these children? You control the fees, but it interferes with their cognitive functions, so their academic performance goes down. So all of this must be taken into account. Next slide. And I think we come to the end of the presentation. Is that okay? Is that correct, Esther?
That's the last slide, Prof.
That's the last slide.
Yes.
Yes.
Okay, I will stop there. I want you to go back to your families. Not to today's Friday evening. I also want to go to mine.
Thank you very much, Professor Ndetei, for that, for educating us. That was quite an elaborately made presentation on focal epilepsy. Before we move on to taking questions, I'd like to welcome our sponsor for the CME, the GSK representative, Mr.
Eddie, how are you?
Prof, I'm fine, although Araka is in charge today.
Christopher.
Yeah,
Yes, go
I
ahead.
have been following you because you are a publisher. You write a lot of good research, so I've been following what you've been doing.
Thank you, Prof.
Yes. Esther, what are you doing?
We want to welcome the GSK representative to give a brief presentation.
Hello, Dr. Haraka. Good evening. Can you hear me?
Yes, we can go ahead.
And confirm you can see my screen as well.
Yes, we can.
Okay, so good evening, everyone. My name is Chris Mbindio from GSK. and I'm here to present what we have as GSK for management of epilepsy. So we have Keppra, which is our brand of levetiracetam, and as we all know, management of epilepsy can be very complex, and that's why we are saying that we need to put simplicity first in the management of our patients with epilepsy. So just as Professor Ndetei mentioned, the efficacy of anesthesia medications is very comparable, both for the older AEDs and also the new generation AEDs. And so this is just a comparison that was done between Keppra and carbamazepine controlled release. And what we can see from this graph is that the efficacy in terms of seizure control for these patients who are in this study population, after 12 months, it was 58.5 and 56.6% for carbamazepine and levetiracetam, respectively. Then in 6 months, 72.8 and 73.0, just showing that the efficacy is very comparable between Keppra and carbamazepine. But then when it comes to Keppra, it approximates the optimal characteristics for an ideal anesthesia medication, and that's why we are saying that you start Keppra in patients with epilepsy as a simple anesthesia medication choice for long-term seizure control. So what are these characteristics of Keppra that we are saying that it approximates the ideal characteristics of anesthesia medication? So with Keppra, it has very minimal drug-to-drug interactions, and I think Professor really dealt on this one, especially for our elderly patients where we are giving multiple medications, where we are managing other comorbidities. And even when we are doing the adjunctive therapy, there is very minimal drug-to-drug interaction of Keppra with the other medications. Keppra has long-term efficacy, which is also required of an ideal anesthesia medication. And when it comes to tolerability, Keppra is better tolerated than the first generation anesthesia medications, just like carbamazepine, which we saw in details in Professor's presentation. There is no need for plasma level monitoring for Keppra. And also to continue with the characteristics, when it comes to the dose titration, Keppra has very minimal requirement for dose titration. It has almost 100% bioavailability and has linear pharmacokinetics. And the dosing for Keppra is convenient because you dose Keppra twice daily. And the time required for Keppra to reach a steady state is less than 48 hours, while for an ideal anesthesia medication would require that fast time to steady state. So Keppra also has got optimal titration that can be achieved in up to 2 weeks. So this is just John, a patient who is 23 years. So this is a patient, an ideal patient of yours who has been diagnosed with epilepsy with focal seizures, newly diagnosed. And so this patient will be worried about the recurrent seizures after the initial episode. So if you are prescribing a drug that will require or will take a longer time to be titrated to the optimal dosage, then John will continue having the worries because you are not sure that the initial dose is going to give seizure freedom, and you need to wait at least for the required time to titrate to the required optimal dosage. So with Keppra, you can be able to ensure that John doesn't have the worries of seizures within 0 to 2 weeks after your initial dosage. So epilepsy being a complex disease, as we have said, and when our patients are newly diagnosed with epilepsy, we all know that it can be a very overwhelming experience to the patients and also to the family, and the anxiety and uncertainty about their future also sets in. And so the compliance and outcome of the management of epilepsy is very important. So that's why we are saying that you need to start with the right anesthesia medication following the diagnosis. So up to 50% of patients with epilepsy will respond to the first anesthesia medication they are prescribed. And also in addition to seizure control, the safety and tolerability, which our professor has really emphasized on, is a very key determinant in long-term treatment of epilepsy patients. And here we are looking at the side effects. We need to also look at the family planning considerations and the impact on the quality of life. And as Professor said, the anesthesia medications have different safety and tolerability profiles. So here we have Anne, who is a female patient, who is also an hypothetical patient who might come to your clinic tomorrow and is diagnosed with focal epilepsy. She's worried about gaining weight with anesthesia medications and how treatment might interfere with her plans to have a baby. So for Keppra, where the people living with epilepsy will be less concerned with treatment-associated weight gain. So this is just a study which was done on the body weight versus the baseline when patients were on levetiracetam versus the placebo. And we can all see that the weight gain with levetiracetam versus the placebo was very comparable. So the Anne will not be worried about the weight gain. And when it comes to the major congenital malformations, Keppra is associated with significantly lower risk of major congenital malformations compared to valproic acid. So our that one odd Anne is also a patient who has got the potential of wanting to have children. Actually, she's at childbearing age. So this patient will not be worried so much when prescribed for Keppra in terms of major congenital malformations for their children. So this again is a representation from this study showing the comparison between major congenital malformation rate versus the different anesthesia medications. And we can see with the levetiracetam, we only add 2.4% as compared to carbamazepine, which is at 3%, and the valproic acid, which is at 9.3%. So even the lowest doses of valproic acid come with significant higher major congenital malformation risk versus Keppra. So this is a Europe study. So we can see here from this study is just comparing the lowest dosage of levetiracetam, which is between 250 to 400 mg, versus the lowest dosage of valproic acid, less than 650 mg. You can see significantly 6.3%. And as the dosage increases, the risk of major congenital malformation with valproic acid also increased. So unlike valproic acid, children exposed to Keppra in utero are not at an increased risk of delayed early cognitive development. So Professor really mentioned about the cognitive development. And so for our patient Anne, in terms of the children they are going to bear when they are on anesthesia medication, from this study, you can see with the levetiracetam, versus the control, there was 99.96% overall development quotient for the cognitive domain, as compared to valproic acid, which only had 87.93% in cognitive development. So what is the dosing for Keppra? So as I said, we need to have simplicity, and Keppra brings in the simplicity. And we have very simple titration for monotherapy in adults aged 16 years and above. The starting dosage for the first 2 weeks is 250 mg BD. And then you just need to increase or decrease after every 2 weeks with 250 mg BD until you reach the maximum recommended dose of 1500 mg BD. And even for the adjunctive therapy, is also as simple as also the monotherapy dosing, where you start with a 500 mg BD and increase or decrease after every 2 to 4 weeks again with 500 mg BD. Again, the maximum recommended dosage being 1500 mg BD for adjunctive therapy. So this is just a representation of the dosing adjustment for adults and adolescent patients weighing more than 50 kg with impaired renal function. So I'll not go into the details of the figures. So I think worth noting is, especially for the patients with end-stage renal disease and patients using dialysis, you only need to do 500 to 1000 mg once a day instead of the BD. Then dosing in children. So it's weight-based, 10 milligram per kilogram twice daily. And also worth mentioning is that the dosage can be increased up to 30 mg kilogram twice daily. And dose changes should not exceed increases or decreases of 10 mg kg twice daily every 2 weeks. And the lowest effective dose in children should be used. And when it comes to children weighing more than 50 kg, those ones are dosed the same as in adults. And so in summary, as we are saying, when you prescribe Keppra for your patient, you are putting simplicity first. So Keppra is a simple and seizure medication choice for your patients with epilepsy. It's broad spectrum and it offers favorable tolerability profile with effective seizure control. And as we have seen in the study, it demonstrated comparable rates of seizure freedom compared to carbamazepine controlled release in patients with newly diagnosed focal epilepsy. And then we also mentioned that it has lower drug-drug interaction potential compared to commonly used anesthesia medications, and that fast titration to therapeutic dose. And mostly the guidelines recommend caution against automatic switching without consent of treating physicians. So here we are talking about switching from a formulation from one manufacturer to the other. And so our clarion call today is you choose Keppra, the simple choice of anesthesia medication with favorable safety and tolerability profile for your patients with epilepsy to achieve long-term seizure control. And just before I go, Professor really talked about the cost of our anesthesia medication, and he explained about that particular patient who could not even afford the 3 meals in a day. And so I want just to share some good news from GSK, just to ensure that we enhance the affordability and also the convenience, and also to ensure that patients continue taking the anesthesia medication they are prescribed for. We have reduced the price of Keppra starting January this year. And for the 250 mg, we have done a 15% price reduction, where our old price was 4,500. This is the price to the patient. That is what we used to recommend to our retail pharmacies. But then again, also different pharmacies will offer different discounts from that particular price. But the maximum old price we used to recommend 4,500. Now your patients can get Keppra 250 mg at 3,800. And this is a pack of 60s. So that means that is a month's dose if they are on 250 mg BD. And so again, with 750, which used to cost 13,000, now costs 9,400. And these prices may be less depending on the discounts the different retail pharmacies extend to your patients. And so to summarize, I'm just displaying a slide here in case you have any safety concerns about our medication and advanced events, then you can email us on the email shown. And for more information, again, also on Keppra and also other GSK medications, you can visit this website. It's called www.gskpro.com. Thank you so much. Over to you, Dr. Araka.
Thank you very much, Christopher. I can see Dr. David Wairoto's hand has been up. Yes, Doc, go ahead. Dr. Wairoto.